Hey everyone, welcome to the presentation of our project. Our project was based on financial performance in relation to quality measurements, presented by Brittany White and myself, Diana Lopez.
The questions that were built on our foundation for our project were: what is the relationship between finance, performance, and quality, and which type of hospitals have the best quality? In order to address these questions, we composed a project that contained 3 categories of variables, which are stated right in the presentation. The 3 categories for the variables being finance, type, and quality.
Moving on to the exploring portion of our project, we're going to present sample bivariate graphs from our project. From the box plot, it is evident that most of our data came from acute care hospitals and some from critical access hospitals. Later, we will be presenting a one-way frequency that supports that discovery, but in this scatter plot, there seems to be a correlation between a dollar amount of assets and the number of 30-day readmission rates. And I'm going to be drawing the slope here. And as you can see, it is a negative slope.
Now, in this scatter plot, it can be observed that as investments increase, the average waiting times in the emergency department before being admitted into the hospital are declining, which is being represented as I draw the line decreasing. Now, onto the next graph. In the box plot, it seems as though metropolitan hospitals have majority of the number of accidental cuts and tears from medical treatment than micropolitan and rural hospitals.
Lastly, this scatter plot seems to have a negative relationship between the dollar amount of adjusted operating expenses and the number of deaths among patients with serious treatable complications after surgery, which I'm going to circle so you guys can see.
Now, from the exploring section, we derived 5 hypotheses to test. The hypotheses were formed from bivariate graphs that seem to have clear relationships. Throughout the rest of this presentation, we'll be focusing on hypothesis 3, which is represented right here that I'm circling. Hypothesis 3 being if types of hospitals are compared to one another by the quality measurement of catheter-associated urinary tract infections, then acute care hospitals will have a higher number of cases.
When testing the hypotheses, we added additional independent variables to get a better understanding of the relationship of the independent and dependent variables. The variables are listed here, and I'm just going to be circling all the variables that we added.
The reason for choosing to further research hypothesis 3 is because all others were not accurate with data given, had a lack of observations, or did not have an immediate solution. For example, in hypothesis 1, only 74 observations were used out of the 4,404. For your enjoyment, we provided the regression models and graphs for the other hypothesis.
Hypothesis 3 was a really good selection because over half of the data was used. What we learned from this regression model was the following. Hospitals that are associated with a medical school have an increase by about 0.48 of catheter-associated urinary tract infections. Facilities designated as a member of the Council of Teaching Hospitals had an increase of 0.11 catheter-associated urinary tract infections. The tech index for this comparison was positive, indicating that more sophisticated services are served and that it is profitable. Hospitals designated as a micropolitan hospital have an increase of 0.068 in catheter-associated urinary tract infections when compared to metropolitan hospitals. To further our testing, we used a one-way frequency that showed the majority of catheter-associated urinary tract infections come from acute care hospitals by about 90%. It can be noted also that 4 out of our 5 hypotheses were supported. And here's that 90% that we talked about. And here are other hypotheses.
Based off of hypothesis 3, we will set a goal to reduce the amount of catheter-associated urinary tract infections. In order to do so, we will be implementing a policy that will result in the hiring of 3 certified assistants per unit per hospital. This will in turn increase intangible assets. Now, in order to move the project forth, we will need a budget of about $150,000 per hospital. The budget was calculated based on a 1 year and 6 months trial period in which an additional 3 certified nursing assistants are hired to work full-time to offer extra help for the focus of this project. We will be observing 1,000 hospitals in which 500 hospitals will implement the experiment, and the other 500 hospitals will be the control group hospitals in which do not implement the experiment. Now, this policy will primarily benefit patients by reducing the amount of care and also hospitals by reducing the costs. This will then improve patient satisfaction and hospital ratings.
The procedures of the policy are as follows. Staff 3 additional CNAs per unit, clean the catheter 3 times per 12-hour shift, train on proper perineal care when hired, ensure catheter is being lifted and drained on each check, limit the amount of days that the patient has the catheter, provide a supply cart nearby for quick access, and provide checklists for CNAs to document completion of tasks.
Now, the experiment will consist of CNAs logging duration of catheter insertions and removal, when properly cleaned, drained, and any other changes. After the trial period of 1 year and 6 months, we will run another bivariate analysis just like the one produced earlier in the presentation. The test will be performed a second time, and if successful, then the policy will be established at the facility.
Issues that can arise that would complicate the results of the testing period would be the failure to document tasks performed and the failure to find CNAs who would even want a job. From our project, we discovered that we could not really identify what types of hospitals had the best quality due to the vast differences amongst each other. Children's hospitals and critical access hospitals are far more specific in the type of care that they provide and often did not have any data that could be compared to that of acute hospitals. Our project underwent 3 different phases that provided us with the knowledge to compose a policy. Those 3 phases being the exploring section, testing section, and confirming section. What we would like for you to take from this presentation is that from these big sets of data, we can learn a lot about it. Remember, data is knowledge. Remember, data is knowledge and knowledge is power.
If you have any questions or concerns, please comment below and we will be sure to address them. Thank you for watching our presentation.